KEYNOTE-426 is a randomized phase 3 study. It is first-line metastatic clear cell kidney cancer as the population. It's a one-to-one randomization of Axitinib plus Pembrolizumab versus Sunitinib. It was positive at its first interim analysis after a short period of time. Follow-up was only 12.8 months at that point, with a hazard ratio for survival of 0.53, which was eye-catching. It received EMA and FDA and other approvals based on that, as you would imagine. It also hit response rate and PFS endpoint. And so overall, we had a new piece of a new weapon in our armory of Axitinib plus Pembrolizumab. There were other trials looking at immune checkpoint inhibitors in combination with VEGF-targeted therapies, bevacizumab and atezolizumab, nivolumab, Axitinib, which did not hit overall survival. What was presented at ASCO just in 2020 was an updated survival analysis, which is essentially a 2-year follow-up period, which is obviously a longer period of time. And what it's told us is the hazard ratios for survival is now 0.68 in the ITT population. We could see that came down a little bit in the intermediate and poorest patients. But overall, it has still achieved this survival signal, which is significant compared to Sunitinib. There is a discussion that's ongoing about whether there's a big difference between that 0.53 and 0.68, and whether that is clinically meaningful. And I think the answer to that question is twofold. Firstly, when you look at the confidence intervals of those two endpoints within those hazard ratios, they are in line with one another. And the 0.68 still represents a very big reduction in the risk of death. There's also a more pragmatic answer to that question, which is inevitably, after the initial trial had read out and was finalized, more patients on the trial will get access to subsequent therapy. And clearly, patients on the trial will be aware the trial is positive. And so therefore, there may be some dilution in that hazard ratio. I think overall, when one looks competitively at other combinations such as ipilimumab and nivolumab, which are available, they're also achieving significant survival advantages. And there will be choice between Axitinib and Pembrolizumab and ipilimumab and nivolumab. The data we saw showed that the response rate and progression-free survival for Axitinib and Pembrolizumab were maintained. And it's still true that Axitinib and Pembrolizumab has the higher response rate and the longer progression-free survival. And so therefore, it does appear that Axi-Pembro is probably better at getting initial control of disease. And that may be important for some patients. And still, the data looks very competitive compared to other combinations that are available. We've seen press releases for cabozantinib plus nivolumab, which is another VEGF with immune checkpoint inhibitor combination. We haven't yet seen that data, but we do have a press release. And I'm not going to comment on that data, but what I would say is we are seeing survival signals now for a second time with the VEGF-targeted therapy immune checkpoint inhibitor combination. And that underpins the hypothesis, the principle, that the combination of active VEGF-targeted therapy and immune checkpoint inhibitors results in an impressive survival advantage. So, in summary, the 426 data has continued to have an impressive survival signal. The response and PFS remained high. This continues to be a very attractive combination for patients.